Okay, so I have not been excited to make a video like this in such a long time. Like, I'm super excited. I found out about this today. I was like, okay, tonight I am going to make a video about this because this is something that absolutely needs to be talked about. This right here, this is interesting. So this is a leaked file from WPATH. And if you don't know what WPATH is, I'm going to read it to you right here. I'm just going to read their stuff here because this is excellently done. But I was so excited when I saw this. I was so excited when I saw this because this is interesting. Like, this is stuff that I knew about. Like, everybody keeps on talking about how this is really shocking. It doesn't shock me in the least because I've heard so many stories like this, and we're going to get into these stories. I've heard so many stories like this, I think I've just become desensitized to it. It's like, oh yeah, that's totally believable. Everything they're talking about here, 100% believable to me because I have done research, I have seen so many personal anecdotes, I've seen so many people talking about having experiences like this. This is real. But the thing is, up until just now, it was something that individuals were coming forward and saying was happening to them. And the doctors and the clinicians and the specialists were all saying, "Oh no, it's great. It's, there's people. This is the puberty blockers argument too. This is all part of what's going on here. Puberty blockers are 100% safe and 100% reversible. Absolutely not. Absolutely not. But when you say that, everybody's like, oh, well, where are you getting your information? Well, one of the big sources of information out there in the world is WPATH. So, where are they getting their information? Let's see. Let's take a look at this. This is wonderful. So it says right here in the preface, and there was so much information. So I strongly encourage you, I'm going to leave the links to this stuff down below. I definitely want you guys, if you have the time or if you feel curious in any way about this information, go listen to the videos. They have actual videos. This is a transcript of a video, so you can actually see the actual clinicians who actually did all this. You can see them saying this. You can make 100% sure, for your own personal clarification and your own peace of mind, that this is not something that somebody made up and put words in their mouth. This is the actual words that they said. You can get the context of the words that they said. Like, this is golden. This is beautiful. I did not have time to go through the entire video. All the things they said, all the things that were exchanged, all the ideas that were put forward, I didn't have the time for that, so I looked at it and was like, okay, what can I realistically put into a single YouTube video that I can give to you guys so that I can, spark your curiosity and, give you access to even more information. Like, just kind of open the door and show you what's inside here, because this is interesting, right? They have a collection of excerpts. Somebody's having a rough night. Okay, so they have a series of excerpts, so if you want just a really quick taste of what the information in these files is, you can get that. And that's what we're going to be looking at right now. I've got the excerpts printed out. We're going to go through those. We're going to talk about those, because some of the terminology that's used, I don't think people who are unfamiliar with transgender issues are familiar with this terminology. And so I'm going to talk about it. And then there's more information available. There were some doctors who got together and they talked about it, and that was really interesting because they talked about stuff I would never have dreamed to even think about. So that's cool. I'll leave a link to that in the description. So really quickly, let's get started with this. WPATH and gender clinicians and activist groups more generally insist that gender medicine is, quote-unquote, settled science. They present puberty blockers, cross-sex hormones, and genital surgeries as evidence-based, life-saving care and suicide prevention. Rachel Levine, the U.S. Assistant Secretary for Health, claims there is, quote, no argument among medical professionals, pediatricians, pediatric endocrinologists, adolescent medicine physicians, adolescent psychiatrists, psychologists, etc., about the value and the importance of gender-affirming care, which is absolutely untrue because I have seen so many doctors come forward and argue against this stuff, but they get drowned out, they get silenced, they get called quacks, they get ignored. But there are absolutely many, many doctors out there who argue against this stuff. They just get drowned out. I'm going to read all this. We're not going to read all that. We're going to get to the good stuff. Okay. Number 1, section 1, I guess. An unethical approach to consent among adults with comorbidities. So this part got interesting really fast. Patients with dissociative identity disorder are regarded as having the capacity to consent to hormones. And I quote from a gender therapist. One client who had dissociative identity disorder, we worked on all alters giving consent to HRT before it was started. They had alters who were both male and female gender, and it was imperative to get all the alters who would be affected by HRT to be aware and consent to the changes. Ethically, if you do not get consent from all alters, you have not really received consent and you could be sued later if they decide HRT or surgery was not in their best interest. This was one of the quotes that was discussed by those doctors, and that was really interesting because it never occurred to me. Their emphasis is on whether or not you're going to get sued for this. That's the big concern. We want to give out the medicine. We definitely want to give out the medicine. But are we going to get sued? It's not whether or not this is the best thing for this patient. This is a patient with dissociative identity disorder, also known as multiple personalities. The science behind multiple personalities or dissociative identity disorder is not good science. In fact, it's a lot of bad science. And for a long time, DID was one of those things that showed up on TikTok all the time where teenagers were like, oh yeah, I have dissociative identity disorder. I have 13 people living inside my head. That's why they call them alters. And they would talk about the different people living inside their heads, and it was kind of obvious that they were sort of, very imaginative young people. There is a lot of skepticism when it comes to dissociative identity disorder. So that's already one of those things that's like, okay, are we dealing with science or are we dealing with pseudoscience? But now they're talking about talking to all the different personalities that this person supposedly has so that they can make sure all the different personalities sign off on receiving these drugs so that they can get these drugs. And it's like, I'm sorry, at that point you kind of have to verify that the person is in a stable and sound enough state of mind to actually agree to take the medication in the first place. And I've seen people, and this is something I've read the articles, I've seen people who are trans who talked about how it's really hard for them to get medical care as transgender individuals because they have a mental illness. And remember that study that I read a while back where it was like, I think there were a few studies that were referenced. It was nearly 50% of the individuals who came to this clinic that they were studying, it was the Italian study, nearly 50% had a personality disorder. And then there was another study that they referenced where it was like 52% of the people had a personality disorder. These are people with mental illnesses. And mental illnesses, I mean, you can't discriminate against people for having a mental illness. That is not fair and it is not nice, but you do have a moral obligation as a care provider to determine whether or not that person is of a stable enough state of mind to make life-altering medical decisions. So it's tricky. I get that it's tricky, and I've seen people, writing articles. It's like, I have bipolar disorder, and just the fact that I have bipolar disorder means that I can't get medical care, and it's very difficult to continue to maintain transgender care, transgender medicine, because once you get on this medication, you're on it for life. It doesn't go away. So they're trying to continue getting their hormone therapy, and it's really difficult because people look at it and say, oh, well, your file here says that you have bipolar disorder. It's like, well, that doesn't go away, but I've been in therapy, I've done my time, I've gone through all the hoops, and I should be able to continue to receive a steady dosage of this medication. It doesn't happen. So I understand the complaint, and I understand there are a lot of trans people who are going to look at this passage right here and say, well, I mean, really, should we discriminate against someone with dissociative identity disorder? It's like, we shouldn't discriminate against individuals who are struggling with mental health problems. However, this is getting ridiculous. This is a person who's constantly swapping back and forth between personalities, who's claiming to want something, but they have to collectively, as multiple personalities, all agree that they want this thing, and it's just kind of... The problem with dissociative identity disorder is when skeptical people have looked at it and said, where's the science to back this? One of the things they've noticed is that the people with DID tend to be highly suggestible. The problem with ROGD, which a lot of people don't want to believe in, but people who are more suggestible are going to be prone to social contagion. So if they're already identifying as having DID, has it yet been clearly established that they really have this disorder, or are they just falling for yet another social contagion? That's a question that I think needs to be asked. Personal opinion. The doctors that were looking at this they were kind of laughing at the dissociative identity disorder because they were like, this is not necessarily very solid science. And again, this is WPATH. These are the people who set the solid science, right? So why are they talking about something fluffy like DID? But then the emphasis on avoiding being sued. It's like, it's not about, at that point, what's best for the patient. It's about, don't get sued. Get the money. Take the money. Totally take the money. Don't get sued. Okay, next quote. Because that one, I can see people arguing on that one. Let's get to some more juicy stuff. Let's see if they have anything a little better, a little richer, a little meatier. Patients with severe mental health issues. In reply to a nurse practitioner who is struggling with how to handle a patient with PTSD, major depressive disorder, observed dissociations, and schizoid typical traits who wishes to go on hormone therapy. Dr. Dan Karasik, lead author of WPATH Standards of Care 8, Mental Health Chapter. I'm missing why you are perplexed. The mere presence of psychiatric illness should not block a person's ability to start hormones if they have persistent gender dysphoria, capacity to consent, and the benefits of starting hormones outweigh the risks. So why the internal struggles as to, quote, the right thing to do? Okay, so this is a person with PTSD. This is a person with major depressive disorder along with their PTSD. This is a person who is dissociating. They're having major flashbacks. And schizoid typical traits, which honestly I'm not so familiar with, so I'm not going to speak on that. But just those three things alone, PTSD, major depressive disorder, flashbacks. This is an incredibly traumatized individual. Maybe when a person is incredibly traumatized, that is not the time to be starting them on hormone therapy and transitioning them over to the other gender. That's the time to take a step back and say, look, I know you want to do this, but let's fix this very, very alarming thing that has happened to you. Let's get that under control first. Let's get you stabilized. Let's get you healthy. And then we can do the gender thing. But right now you're struggling a lot. And if you're struggling just to get through your day, if you're struggling just to function, this isn't the time to make major life changes. Like, I thought that was common sense. If you've been severely traumatized and you're having flashbacks and you're severely depressed, that's not the time to go making major life changes like, oh, well, you know what, I think I'm going to switch careers. Or, oh, well, I think I'm going to divorce my husband. Oh, well, I think I'm going to switch genders. That's not the time to be doing that. You got to stabilize yourself. You got to get yourself grounded first. I would think that would be common sense, personally. Now, again, he's saying we shouldn't discriminate against people just because they have a mental health disorder. I understand that for people who have a persistent mental health disorder. So people with autism who get really annoyed because they're trying to get transgender medical care, but they're autistic, and so everybody's like, well, let's cure your autism first. It's like, okay, let me get my popcorn out. I'm going to sit back and watch how this works out, because so far we don't exactly have a cure for autism, so what exactly are you suggesting, right? There is that, but then there's this, where this is all kind of acute stuff, and this is all really alarming stuff, like PTSD. Something bad happened to this person. they're dissociating, so they're having flashbacks. They're really messed up over what happened to them. They're extremely depressed about what happened to them. Now, everybody always talks about how being trans causes suicidal ideation. This recipe right here, these other three things that have nothing to do with being transgender, those will cause suicidal ideation. Let's just not pile more intense hormonal changes and weird emotions and transition, which is a very extreme process. Let's not pile that on top of all that. Can we just give this person a little bit of time, like a couple of years, to just pull themselves together? Can we give this person some good therapy so that they can get their life under control before we shove all this on top of them too? Isn't that good medical practice? What the hell? And I know there are going to be those people, because I've heard the arguments. I know there are going to be people who are like, well, maybe this person has PTSD because they're trans. Really? Really? This is the thing that bothers me. It's this chicken and egg argument that they want to make that doesn't make a lick of sense. Trans people are traumatized and mentally ill and struggling with all these problems because they're trans and society is mean to them for being trans. And I'm sorry, I just don't see it. I do not see that at all. It makes so much more sense to say sometimes people have messed up things happen in their lives and they adapt to those. And sometimes one of the adaptive measures that people take, certainly the adaptive measure that I took in my life, was to start craving becoming the other gender. That's why I'm weird, folks. I survived a lot of messed up shit and I'm still alive, but that doesn't mean I don't have my quirks. I've accepted this. But then I see all these people who are like, no. It was because you were transgender that all this bad stuff happened to you. And I'm like, I'm sorry, that is the funniest thing I've heard in a good long while. So, whatever. You can make that chicken and egg argument, but when you look at this, again, these are the people writing the best clinical practices. Are you sure you're going to take someone who's in a state of mental health crisis and pile a bunch of hormones on top of them? Are you sure that's a good idea? Are you sure there, doctor? Remember, this is the guy who was the lead author of the WPATH Standards of Care 8 Mental Health chapter. I don't trust this physician just based on this quote alone under these circumstances. I do not trust this physician. I would like to seek a second opinion, please. Mentally ill and homeless people are regarded as suitable for referring for genital surgery. This gender therapist was kind of a trip. I think it's a she, but anyway, this person. I have also intervened on behalf of people who have been diagnosed with major depressive disorder, complex PTSD, homeless, and got at least an orchiectomy. In the last 15 years, I had to regrettably decline writing only one letter, mainly because the person evaluated was in active psychosis and hallucinated during the assessment session. Other than that, nothing. Everyone got their assessment letter, insurance approval, and are living, presumably, happily ever after. This person green-lighted everyone. Anyone who came to them got a green light, except for that one poor soul who literally started having hallucinations in the middle of his assessments. And at that point, even this therapist couldn't quite greenlight him for that. Like that, you're gonna get sued. Is this therapist actually taking the time to make sure that these people actually need transgender medicine? Because it really doesn't sound like it. It sounds like she literally, I think it's a she, I could be very wrong. It sounds like she literally just greenlighted everybody who came through and regretted the one person that she couldn't greenlight on a technicality because he was psychotic and he was having hallucinations. This would be comical. This would be comical if it was if it was a story, if it was made up, if this was fiction, we'd all be laughing right now. This is reality. These are the people who wrote the standards of care. Green light everybody. Green light everyone. Everyone should have access to this medicine. And you might be thinking everyone should have access to this medicine. And it's like, okay, everyone should have access to medical care, but it is my very strong opinion, and I think it's the very strong opinion of many people, everyone should have access to appropriate medical care. Everyone should have access to honest, actual medical care. Not just, if I go into my doctor tomorrow and say, hey, you know what, I think I should do some chemotherapy. My doctor is going to look at me and say, why do you think you need chemotherapy? Not, oh, okay, if you want it, you should have access to it. That's not how medicine works. But the way WPATH does it, that's absolutely how medicine has been working. And it is a farce. It is comical. It is sort of horrifying, really. And this is the point at which I think it's really important to mention those doctors who did that video. I'm going to post a link right here. Actually, I'm going to put the link up right here, right now. These doctors, one of the things they brought up at this point is, if you're giving a homeless person an orchiectomy, which if you don't know what an orchiectomy it is, it's literally having the testicles removed. So they're removing the testicles for some homeless gentleman, right? If you're doing that, how can you make sure that that person is going to be able to keep up with their follow-up care if they are literally homeless? If they don't have a place to live, how can you be assured that they are going to continue with the necessary follow-up care of an invasive surgery like that? That's a good question. You're giving these surgeries, these very invasive, very life-altering surgeries to these people. Have you determined not only that they are capable of consenting to these medical procedures, which I think is dubious, especially after some of the quotes I've just read, but also that these people are capable of doing the necessary follow-up care for these procedures? It's all good and well to give a person a vaginoplasty, a homeless person a vaginoplasty, but they're going to have to do follow-up care on that. They're going to have to, insert I forget the term, they're going to have to insert a rod into that vaginoplasty to make sure that it doesn't close up on them, or they could get very, very sick and die. And that rod has to be clean. If you're homeless, are you living in a clean enough environment that you can do that follow-up care? And maybe they're not doing vaginoplasties on homeless people, but they definitely did, they're definitely doing stuff. They're definitely doing stuff on these people, even if they're homeless. That's a really great question I never would have thought to ask, but these doctors are asking it. So definitely watch their video. Watch their video if you're curious. Like, this is enlightening. And not in a pretty way. Definitely not pretty at all. There is a lack of concern regarding young people regretting sacrificing their fertility. This part I thought was really interesting because I've had so many people that I've talked to who've been like, well, it's only 1% regret rate, or even less than 1%. So really, virtually no one actually regrets these procedures. And I don't believe that for 1 second. You can quote that statistic at me again and again and again until you're blue in the face. I'm not seeing it in the world around me. I'm not seeing it when I listen to detransitioner after detransitioner after detransitioner after detransitioner all telling their stories. They can't all just be 1%. There are way too many of these people. Way too many. So anyway, what does WPATH have to say about that 1%, huh? Some of the Dutch researchers gave some data about young adults who had transitioned and had reproductive regret. Like, regret. And it's there. And I don't think any of that surprises us. Dr. Daniel Metzger, Canadian endocrinologist. These people are sterilized. They're never going to have kids. They regret it. Maybe they don't regret transitioning, but they definitely regret losing the ability to have children. That's a regret. That's a big regret. That's the kind of thing that really sits heavy on a person's heart. That's a big deal. Do we hear about that? Do you hear about that? Like, when does WPATH say, oh yeah, there's a risk of severe regret when it comes to not being able to have kids because you got sterilized as a child? When is WPATH coming out and saying that? Have you ever heard WPATH come out and say that? I haven't heard them say that yet. Minors offered life-changing interventions they cannot fully understand. Concerning whether it is reasonable to expect children and young adolescents to grasp the effects of gender-affirming care. It is out of their developmental range to understand the extent to which some of these medical interventions are impacting them. They'll say they understand, but then they'll say something else that makes you think, oh, they didn't really understand that they are going to have facial hair. Diane Berg, child psychologist and co-author of the child chapter of WPATH Standards of Care 8. These are the people who wrote the Standards of Care. They wrote the book on how to do transgender medicine. This lady here wrote the book on how to transition children. And she herself is saying, yeah, they say they understand, but they don't really understand. And I've seen this myself. I've seen this online. I've seen people who go online and they're like, yeah, I want to take hormones, but I don't want to have bottom growth. Which, in case you're not familiar what bottom growth is the fact that when you put testosterone in a woman's system, her clitoris enlarges like a tiny penis. And I guess some of the women who are contemplating taking testosterone, they want to have, certain male features. Maybe they want the square jaw, and maybe they want the more bushy eyebrows or whatever. Maybe they want to have bigger muscles, what have you. But they don't want to have that down there. And one of the things numerous people who have taken those hormones have said, you don't get to pick and choose what kinds of results you get when you take these hormones. Like, testosterone is going to act on your body the way testosterone acts on a human body. If you want to look like a man, you're going to look like a man. But you don't get to go through like a checklist of male traits and be like, well, I want to have this handsome trait and this handsome trait and this handsome trait, but I don't want to have a hairy back. You don't get to make that choice. These people don't always understand that, particularly the very young ones. And WPATH, the people who wrote the book on the standards of care, they know this. They know this. They're talking about this. Like, this would be one thing if a bunch of child psychologists got together for coffee one day and said, yeah, I don't think these kids get it. Like, when we're doing these procedures to them, when we're signing off on these medical things, I don't think these kids fully get it. That's one thing. And that's kind of a problem when a bunch of doctors are getting together and saying, yeah, I'm doing this stuff and I don't think these kids fully understand what's going on with them, right? It's a whole nother level when the professionals, the experts who write the book of rules on how to do this, they themselves say, yeah, I don't think these kids actually know what they're getting into. But they're still saying we should do this to them. Even if they don't know what they're getting into, we should totally do this to them. We're often explaining these sorts of things to people who haven't even had biology in high school yet. Dr. Daniel Metzger, Canadian endocrinologist. People who don't understand biology. Children who don't understand basic biology. We're going to do something really complicated and biological to you. It will change your life forever. But you don't know what it is. You don't fully grasp it. You haven't actually had enough biology classes to understand what is about to happen to you when we perform these medical procedures on you. And I mean, what was her name? Brianna Ivy. I think it was Brianna Ivy, wasn't it? She was talking about how she honestly thought that she was going to be a real girl. So she agreed to all these procedures, she did all these surgeries, she did all this medical stuff. She thought she was going to get to be a real girl. Because she was a kid. And she didn't understand, if you're a biological male, you never get to be a real girl. Me, I'm an adult. I'm not undergoing these procedures. You know why? Because I'm never going to get to be a real dude. I might want to be a dude. Never going to be a dude. I've accepted this. Biology is important. If you're too young to understand biology, that's a problem. Dr. Christine McGinn, American plastic surgeon, reported performing about 20 vaginoplasties on patients under 18 over a 17-year period and confessed that, quote, not all had perfect outcomes. How many times did vaginoplasty fail? Like, remember, 1% regret rate, right? So how many times does vaginoplasty fail? Because, I mean, again, she's done 20 of these. 20 of these, right? On patients under the age of 18. So on kids, legal kids in our country. Because she's an American. She's doing this on people under the age of 18. Those are children by our laws. She's doing these things on children. And of the 20 that she's done, not all had perfect outcomes. So what is that regret rate again? 1%? Less than 1%? But they didn't have perfect outcomes, did they? No regrets. No regrets at all. And these are the experts. These are the experts who are writing the rules on how this is supposed to be done, and they're not all having perfect outcomes. That's a little unnerving. Like, what is the failure rate on this procedure? You're doing this to children who are not yet of legal age to consent to these kinds of procedures. What's the failure rate? Give me numbers. I think we all deserve numbers on this. On the complexity of discussing fertility preservation with children and adolescents during an internal panel discussion. A WPATH internal panel discussion. The experts who write the rules on best practices. It's always a good theory that you talk about fertility preservation with a 14-year-old, but I know I'm talking to a blank wall. They'd be like, ew, kids, babies, gross. And then a little while later, I think now that I follow a lot of kids into their mid-30s, I'm like, oh, the dog isn't doing it for you, is it? They're like, no, I just found this wonderful partner and now I want kids. So I think, it doesn't surprise me. And a little while later, most of the kids are nowhere in any kind of brain space to really talk about fertility preservation in a serious way. And this was Dr. Daniel Metzger, Canadian endocrinologist again. The dog isn't doing it for you. I mean, I understand he's a doctor, he's talking with his patients, he's probably trying to make friendly, amicable conversation. You can't have kids, you can't have children. The best you can do is get a dog. This doesn't upset people who haven't yet decided that they want to have kids. And I remember being 14. I think a lot of people who are adults now remember being 13, 14. Ew, kids, I don't want to have kids. I didn't want to have kids. For years and years, I didn't want to have kids. I used to have nightmares about having kids. I had nightmares about having children. I didn't want to have children. Seemed like the most horrific thing in the world. I did not want to have kids. Then I met my husband. I am currently pregnant with baby number 5. I kind of changed my mind. You change your mind about these things sometimes. Like, if you don't have a particularly good mate and you're not of an age or a place in your life where you are prepared to have children, the idea of having children is not appealing. When you do find an attractive mate and you are in a place where you are ready to have children, like an adult, all of a sudden you start wanting these things. And for these kids, by that point, it's too late. And again, regret. We're looking at regret right now. Is this really just a 1% regret rate? How many of these people have serious regrets? And we're only being told, oh yeah, it's only a 1% regret rate. We should totally just do this to everybody. We should, green light everyone. Why is this a good idea? Why are these people saying that this is okay? And again, this isn't just a group of doctors that met up for coffee one day and started airing their grievances about the way the medicine is being done. These are the experts who write the rules that everybody else is supposed to follow. These are people who are saying that everyone is all in agreement and no one is questioning these rules. Let me go back to that quote. Let me find that quote again here. Ah, there you are. Okay. Rachel Levine, the U.S. Assistant Secretary for Health, claims that there is, quote, no argument among medical professionals, pediatricians, pediatric endocrinologists, adolescent medicine physicians, adolescent psychiatrists, psychologists, etc., about the value and the importance of gender-affirming care. We should totally do this to kids. Somehow this is supposed to be acceptable. Okay, now they move on to extreme body modification with no medical justification. And this was interesting to me. And I have some observations that I want to make on it that are just personal observations I've made in my own research. So this should be interesting. Okay, so full disclosure, I have researched double mastectomies for myself for years now. And I have wanted one for years. I don't know if I would get a full double mastectomy because I'm married. My husband kind of likes this part of my anatomy, so I don't want to like take it away from him. But I have done a lot of research into breast reductions, double mastectomies, things like that. I was a stripper for 8 years, so everybody got a boob job. Like, that was just the world I lived in. As an exotic dancer, everyone gets a boob job. It's only a matter of when. And the way I always looked at it was I was very well endowed when I was younger. And I looked at it as like, okay, if I ever get any work done, it's going to be when these things start being affected by gravity, and I'm going to have them either lifted back up again or just, reduced to the point where they're not going to be sagging all the time. Like, that's a cosmetic procedure. In my opinion, that's a cosmetic procedure. It's not necessarily gender affirming care. I don't want to make them look like man chest. Honestly, I want to get rid of them because they're heavy and they're uncomfortable, all that stuff. They're annoying. Obviously, right now, I'm pregnant. I'm really glad I have them. They're very serviceable, but,
I realized after filming this that the point that I really need to make is that I am an adult nearing the end of her reproductive life. Once I am no longer producing offspring, that part of my anatomy becomes a cancer risk. And having a history of cancer in my family, I'd be just as happy to remove it. This puts me in a very different place in my life's journey than a young person who has never had a child and doesn't understand what they'll be losing by removing that part of their anatomy.
So when they talk about, and I'm going to read this quote, I've performed mastectomies without nipples, or have created chests with varying degrees of remaining breast tissue, or created incision patterns specific to my patient's wishes. Honestly, as a person who's been shopping around for the best possible way to get a breast reduction for cosmetic reasons, that sounds lovely. If you're going to a plastic surgeon and getting, a cosmetic procedure, that does actually sound quite nice. And the nipple thing, that's the thing I was going to talk about. So I was doing my research, and when they do double mastectomies or, gender affirming top surgeries, things like that, I was researching, and sometimes when I research, I read everything that I can possibly find. I found a video of the actual procedure, and I watched the entire video, which was very difficult because I like to think I have a strong stomach, but watching a human being chopped open and cut to pieces and then sewn back together again is, it doesn't always sit comfortably on your stomach. Not gonna lie there, it was not a pretty experience to watch that whole thing happen, and I always thought that I had a pretty decently strong stomach. It was just not pretty. It wasn't unbearable. I wasn't feeling like I was gonna barf or anything. It was just not the most comfortable thing, and probably because I was contemplating having that done to myself, and it's like, yeah, I think I might want to do this to me. And then I watch a video and it's like, maybe I don't want to have this done to me after all. This does not look like comfortable for me. No, maybe not. But I'm watching this video, and they're taking the nipples, and they remove the nipples as skin grafts, and then they graft them back onto the body. That graft doesn't always take, and there are many accounts of occasions that that graft did not take and it didn't heal properly and it caused a lot of issues. And there's a loss of sensation anyway, so it's like, what's the point of keeping it? I understand people wanting to have this procedure without nipples, because when I was doing my research, I found out that you can get fake nipples. And you can be absolutely certain 100% that the nipples are going in exactly the place that you want them to go. As the healing process goes on, they're not going to migrate, which was a problem. They don't always stay right where they're supposed to stay. They're not going to get pulled in any direction that they shouldn't be. They're not going to get tugged. They're not going to be malformed. And they're not going to get rejected by your body and fall off, which would be really a disturbing experience to have, I would imagine. I totally understand people opting for the surgery without the nipples simply because it's easier to get fake ones, but these aren't necessarily people who are having fake nipples applied later. Also, I should mention that one of the reasons that I'm doing a lot of the research on the breast reduction / removal thing is because there's a history of cancer in my family, and I looked at it, was like, I don't think we have that gene that causes cancer, where it's like you really do need to have a double mastectomy because you will get cancer. It's more like we just have a history of cancer, and so I'm trying to be vigilant about that. And it's like, well, if I get a reduction, that would make my life possibly a little safer, which might be maybe not the worst idea. But yeah, I can understand that. So I will say, like, in fairness to them, I do understand this part. However, he goes on to say, for bottom surgery, I've performed minimal depth vaginoplasties, vulvoplasties, phallus-preserving vaginoplasties, and nullification procedures. I'm quite comfortable tailoring my operations to serve the needs of each patient. Phallus-preserving vaginoplasty. So you have a penis and you have a vagina. You got both. It sounds a little bit... I guess the question that comes up at this point is, how is this best medical practices, and where is the research on some of these procedures and some of these double penis vagina kinds of combos? Where's the research behind this to prove that this is, as many people say, life-saving medical care? Like, people are suicidal and they need transition, otherwise they're going to commit suicide. That's the narrative we're all being fed. This looks like cosmetic surgery. And again, I'm looking at the same cosmetic surgery for myself someday. Like, this is on my wish list. Like, if I had a bunch of extra money just kind of fall on top of me and, like, one day, like, oh, here, congratulations, you're just a lucky person. You know, would I want to spend some of that money to get some work done? Oh, yeah, I totally would. It's cosmetic at that point. But these are the people writing the best practices for medical care. Where is the research suggesting that it is good to have both a penis and a vagina? I'm curious. And then you get to nullification procedures. And that's where I look at it and say, okay, there's something kind of questionable here. Nullification procedures, I had to go look it up to make absolutely certain, and I'm going to give you this lovely little quote right here, which I don't have printed out, so I can't read it to you at the moment.
The nullification procedure typically involves removing specific genital tissue or altering it to create a more neutral or non-binary appearance, leaving only the urethral opening. For those with male genitalia, options include penectomy, pretty self-explanatory, orchiectomy, the removal of the testicles, scrotectomy, and urethral shortening. For those born with female genitalia, options include hysterectomy, that sounds like a rather involved procedure, vaginectomy, vulvectomy, clitorectomy, and urethral modification. So that helps clear that up now.
Basically, they're performing surgery on individuals who say that they're trans, frequently non-binary individuals, and making them basically look like Barbie and Ken dolls. Just blank slate. Nothing down there. How is that best practices? Where's the research on that? Where's the research on the satisfaction rate? Remember, 1% regret rate. Where's the research on the regret rate after you get turned into a Ken doll with nothing down there? Where's the research on this? They're doing this. They're performing this. Really looks like they're flying by the seat of their pants here. And I would understand if it was just cosmetic surgery, but this is a super invasive cosmetic surgery. They are cutting off people's penises, they're cutting off testicles, they're cutting off scrotums, they're cutting off the works. They're cutting off people's genitalia and making them just look like a blank Barbie doll. Where's the research that says this is life-saving medical care for trans people who are suicidal if they don't receive it? Where is that research? Because this seems like a pretty darn extreme cosmetic change. And I'm sorry, this extreme body modification sounds much more like a cosmetic thing than a life-saving transition kind of thing. Because they're not making stuff that you find in nature. It is extraordinarily uncommon to find someone with both a penis and a vagina. But that's what they're building. And another concern that I personally have, and this is just a personal concern, what kind of people are asking to have their body turned into just a blank kind of Ken doll or Barbie doll body? And the reason I'm asking that is victims of sexual abuse are going to want to escape their sexual characteristics, their physical sexual characteristics. They're going to want to escape their breasts. They're going to want to escape their vaginas. Maybe they're going to want to escape their penises because little boys get sexually abused too. Just because they want these things in the wake of unspeakable abuse and very unacceptable abuse, does that mean that we should just give it to them in the moment? Or should we make absolutely certain that we have given them therapy if they need therapy and helped them to come to terms with their body and come to terms with the things that have happened with them before offering them an extreme and irreversible procedure like having their genitalia cut off? Like, is that being done? Is that precaution being taken? Detransition and suicide prevention. In reply to a post about a detransition study, acknowledgement that detransition exists even to a minor extent is considered off limits for many in our community. WPATH President Marcy Bowers. It happens and we shouldn't talk about it. I've noticed that. I talk to trans people online and it's like they've got this giant blind spot when it comes to detransitioners. And I'm like, listen to the detransitioners. We have to listen to them. They're part of this equation. What do they have to say? It's not transphobic to talk to people who are detransitioners. It's not transphobic to take into account their experiences. If anything, it helps people who are transgender to learn and find ways to pursue their own personal goals in a safe, healthy manner. Like, the idea isn't necessarily just to transition. The idea is to be healthy, happy, satisfied, and comfortable inside your own body. That's the goal. Transition is supposed to be a route to that, but people treat the transition like the end-all be-all, and it's like, not everybody needs the same things. Where's that in the WPATH standards of care? All they ever talk about is transition. What is problematic is the idea of detransitioning as it frames being cisgender as the default and reinforces transness as a pathology. It makes more sense to frame gender as something that can shift over time and to figure out ways to support people making the choices they want to make in the moment, with the understanding that feelings around decisions may change over time. This was a researcher they're quoting. Dude, that's a load of bullshit right there. Okay, this is supposed to be the settled science, guys. They're trying to figure out ways to frame it so that it sounds pleasant. They're trying to frame ideas to make them palatable. If it's science, you should be looking at it and saying, this is what the data is telling us. These are what the numbers are telling us. This is what the numbers suggest. This is what the numbers imply. We're going to go with this. Science isn't about science isn't about coming to one conclusion and being like, all right, this is it. We don't ever have to ask questions anymore, ever again. Science is about always looking for the next question to ask. That's what science is. And I'm not even a scientist. I'm a retired stripper with a high school diploma, and I know this. You always ask the next question. Every question leads to more questions. Your understanding of anything is always in a state of evolution and growth. So you don't say, oh, the idea of detransitioning is problematic because it makes cisgender people seem like they're the default, which, hey, by the way, they are, in case you didn't notice. And it reinforces transness as a pathology. We don't want to make trans people look bad because the politics and the optics on this issue are so much more important than the science. That's what they're saying. That's literally what they're saying here. So let's frame it in a way that makes it more appetizing. Let's make it more palatable. Let's make it nicer. Forget the science, forget the data, forget the information, forget the growing and evolving understanding of the field. Forget all of that. We need to make this look good. That's literally what he's saying here. And then gender is something that can shift over time, and to figure out ways to support people making the choices they want to make in the moment, with the understanding that feelings around decisions may change over time. 1% regret rate. How much bullshit are you guys shoveling? I'm sorry, like really, how much bullshit are you guys shoveling? Explain this to me in a way that doesn't make it sound like absolute bullshit. Please. Like, I don't want to be hurling out accusations that are unfair here, but how is this not absolute bullshit? Feelings around decisions may change over time. Well, I really felt like having my balls chopped off was a good idea at the time, but now that it's happened, I'm really feeling like that was a terrible, terrible mistake. I could talk about this quote for hours. I could talk about this quote in the context of my own life. I could talk about this quote in the context of things I've read about autogynephilia. I could break this down for hours. But at the end of the day, they're talking about framing things in a way that makes them feel a certain way and seem a certain way. Let's not let people think that to be transgender is in any way pathological. That would be bad. We have to frame it in a way that makes it seem, like it's just as default as being cisgender. Let's ignore the science, let's ignore the data, let's ignore the research. Let's frame this so that it has a certain political feel to it. Everything's about feelings here. Where are the numbers in all this? Like, really? Where's the science? Where's the, okay, we know this for sure, so from that information, we should base our next decision on this. Where has anybody, in any of these quotes that I've read so far, said something like that? We know this, therefore the next course of action should be this. Because I thought that was how science worked. And again, this is the settled science. These are the experts. Sounds like they're asking a lot of questions, and quite honestly, it really sounds like they're flying by the seat of their pants. But, I'm not a doctor. Maybe I'm wrong. Explain this to me. Somebody clarify this for me. In reply to a therapist concerned about a 13-year-old non-binary natal female with an eating disorder who is requesting testosterone, a pediatric endocrinologist recommended the child, quote, be living as the other sex for 6 to 12 months and have, quote, at least one supportive parent. She added, it's very difficult to ask that they wait until 16 because by then they will be dealing with menstrual periods and complete breast development. Waiting appears to increase the rate of suicide attempts. Waiting appears to increase the amount of suicide attempts. Where's the settled science on that? Where's the statistics? Where's the, we know for sure that waiting increases the risk of suicidal attempts? Where is that? Waiting appears to cause more problems. Appears to. Appears to? You're going to sterilize a 13-year-old girl because waiting appears to cause more problems? Appears to. I really hope that they're basing these decisions off more than just appearances here. I really do. Serious side effects and common post-surgical complications. An exchange between two doctors about the severe, potentially fatal side effects of testosterone use in natal females. Testosterone is a known carcinogen. When does WPATH warn people that testosterone will give them cancer? Have you heard anything about that? I haven't heard anything about that. Where's that in the WPATH standards of care? Hey, by the way, you're going to get cancer from this. Are they telling people that? Are they making sure? That seems like something important that if I was going to be taking a medication, I'd want to know if it was likely to cause cancer. Just a thought. 16-year-old female patient found to have 2 liver masses, hepatic adenomas, 11 by 11 centimeters and 7 by 7 centimeters. Damn, those things are big. And the oncologist and surgeon both have indicated that the likely offending agents are the hormones. We are prepared to support the patient in any way we can, example, top surgery when medically stable, etc. One of the doctors. The testosterone she's taking is giving her cancer. This is a 16-year-old. This is a kid. Do you know how big an 11 centimeter tumor is? This is a child. What are we doing here? How is this okay? How is this okay? I have one transition friend/colleague who, after about 8 to 10 years of testosterone, developed hepatocarcinoma. To the best of my knowledge, it was linked to his hormone treatment. It was so advanced that he opted for palliative care and died a couple of months later. Doctor. I had a friend who transitioned and took testosterone, and then he got cancer and died. Are we telling people about this? Are we warning people about this? I see so many stories about kids who go into Planned Parenthood because they want testosterone. They want it now. They want it right away. And they can get testosterone like super quick through Planned Parenthood. God knows Planned Parenthood is having some issues giving abortions out, so, what else are they going to hand out like candy? Testosterone, man. I hate Planned Parenthood. I'm going to tell you guys right now, I hate Planned Parenthood with a deep and fiery passion, so don't expect me to be fair with them. But is Planned Parenthood telling all these teenagers who are coming in asking for testosterone, by the way, this is going to give you cancer? Not a sure thing. What's the rate that people get cancer from testosterone? Have we done any research on that? Standards of care? Have we done the research on that? Speaking of a young patient who developed pelvic inflammatory disease after 3 years of testosterone. According to this nurse practitioner, the patient has atrophy with the persistent yellow discharge we often see as a result. Let me elaborate on that for you. I actually learned about this one from Buck Angel. And I know a lot of people are like, well, Buck Angel is a transphobe. Buck Angel is a transgender man who has been transitioned for what is it, 30 years? He's made so many videos about proper health care for transgender people. I think specifically transgender men because that's been his area of experience, but he has warned so many young trans men about some of the complications that come with regular use of testosterone. Because Buck Angel nearly died because of complications caused by his testosterone use. And luckily they caught the issue on time and they were able to save his life, which is really awesome. But this is something that's not talked about. And I have seen interviews where Buck Angel is interviewing, a trans person, because he does interviews. That's his YouTube channel. He's always doing interviews with people, detransitioners, people who've transitioned, people from all over the world, right? And he did an interview with a young trans man, and that guy thanked him for informing him about this particular problem. I guess what happens is if you don't have enough testosterone, the cervix will harden and seal up, which seals off the uterus, which is a lot of bacteria that lives inside of it. The uterus is a self-cleaning system. It's full of bacteria. The bacteria is constantly draining out and being cleaned out, and it's this whole biological process. Well, if you seal that off, all of a sudden you've got a bag of bacteria that is sealed inside of your abdominal cavity. And if it's not cleaning itself anymore, it can very easily become infected. And that can cause all sorts of health problems. And that's what happened to Buck Angel, and he's been warning trans men ever since. You need to put a little bit of topical estrogen onto your cervical area so that that doesn't seal up. Otherwise, you are going to need an emergency hysterectomy if you're lucky enough to get to the hospital on time. And so when they're describing, and these are the experts, standards of care, they're describing atrophy with persistent yellow discharge. Did they warn this young patient that her genitalia was going to atrophy and start oozing yellow pus? Did they warn her about that? Him? Did they warn him about that? And describing young natal females developing, quote, pelvic floor dysfunction and even pain with orgasm. As a person with pelvic floor dysfunction, I can say that it is absolutely hell on earth, and I would not want to wish that on anyone, especially a young natal female. These are young women, okay? I got my problem, my injury, I got that when I was about 28, and I'm angry because that was way too young to have that happen to me. These are 16-year-olds and 14-year-olds and 18-year-olds. It's like, I thought I had it bad. This is bad. Pain with orgasm. Ouch. How are you supposed to have a healthy sex life? And then, maybe it doesn't matter because you're too young to know what sex is. In some of these cases, that is the case. We are giving these medications out to kids who are way too young to know what that is. That's not good. Puberty blockers? If you're a kid who's taking puberty blockers to stop you from going through puberty, you're probably too young to understand the value of, for example, an orgasm. I used to have bleeding after penetrative sex. It would hurt to have an orgasm. My uterus atrophied also. Trans-identified female emergency medical technician. Paramedic. Yeah, that doesn't sound good. I've heard a lot of stories like that. None of this surprises me. None of this shocks me. It's a little upsetting that the highest experts in the field, the people who write the standards of care, they know about all this. They're talking about all this. I bring stuff like this up and people are like, well, you're listening to right-wing conspiracy theories. What happens when they're the ones who bring it up? What happens when they're the ones talking about it? This is very normal in transgender medical care. Vaginal atrophy, uterine atrophy. Pelvic floor dysfunction? Seriously? Cancer? Pelvic inflammatory disease? These are painful, painful conditions. There's a lot of pain written on this page right here. A lot of human suffering. This is normal in transgender medicine. How normal is it? Where's the study? Do a study. Let me know. Give me some numbers. Where are the numbers on this? Because you hear stories about this. You hear stories about this all the time. If you go looking for the stories, they're out there. How often is this happening? How many people, yeah, they get their transition and they're really happy that they transitioned, but damn, are they in a lot of pain? How often is that happening? Natal male patients on estrogen are described experiencing erections feeling like broken glass. A registered nurse. Erections that feel like broken glass. That sounds like living through a nightmare. How is that not living through a nightmare? How is this okay? How many people is this happening to? They're describing male patients. Patients plural. How many male patients have taken estrogen and discovered that now their erections feel like broken glass? How many times has that happened? That's not okay. It shouldn't happen even one time, honestly. How often does that happen? What's the rate of that happening? Do men who are given estrogen, are they being properly warned? By the way, there is a risk of a side effect which involves erections that feel like broken glass. Are they being told that when they're given this estrogen? Have we studied this? This is WPATH. These are the people who write the standards of care. Why are they not clamoring like we need to do a study like right now? In fact, we need to do a study yesterday. We need to do a study last week, last year. We need to go back in time and do a study just to figure out how often young men taking estrogen feel like their erections are full of broken glass. We need to know that now. And quite honestly, while we're at it, we should probably do some studies about the pelvic inflammatory disease, the pelvic floor dysfunction, the cancer. You know, broken glass sounds painful, but cancer doesn't feel too good either, I'm sure. I don't think anyone wants the organization that writes the rules, the organization that writes the best practices that everybody likes to quote. These are the people writing the best practices, and it's all a risk-benefit decision, you know? I mean, there's going to be some risks. There's going to be a lot of risks, but maybe it's going to be better in the long run. How seems like a really, really iffy kind of decision to be making, especially when, you know, erections that feel like broken glass. I think that's going to be my quote for the rest of my life. It's like, oh yeah, erections that feel like broken glass. Let's not forget those. Let's never forget those, because I mean, I've never had a penis, and I've definitely never had an erection, but if I had one that felt like broken glass, I don't know what I would do with myself. I think that would be a nightmare if it happened just once. I can't imagine if it happened multiple times. That sounds pretty bad. You know, cancer sounds bad, but I think we're all familiar enough with cancer. It's like, well, there's any number of things that can cause cancer. How many things in this world cause erections that feel like broken glass? I just want to know. I want to know. And like I said at the beginning of this video, like, if this would all be comical if it wasn't real, but it's real. These are the people who write best practices. This is the standard of care. The standard of care seems unnervingly comfortable with the fact that there are some things that can go seriously medically wrong with their patients. These are the people who wrote the book on gender care, my friends. I never really trusted them because I kept hearing all these really bad things about them, but maybe after hearing this, you will understand why I've been so dubious of their work. It's not just because I want to avoid the science, it's because I keep reading through their quotes, their own words, their own spoken words. And if you don't want to listen to just the words, if you want to actually listen to the video and see their own lips moving as they talk about these things, you can do that. Like, here's the link. Here's the link right here. Go watch the video yourself. Listen to their voice as they say this. Listen to the tone of their voice. Listen to the words they say as they say it. Listen to the context. Context is everything, right? Let's not ever run off with the assumption that these things that they're saying were taken out of context. We have the context. Go watch the video. You'll get all the context you want. This is ridiculous. Anyway, this has been a very long video. I'm going to have to edit it down as much as possible. I was excited about this because, I mean, I've been frustrated recently because I've been trying to talk to people, and it's very difficult to talk to people when one group has one set of science and the other group has another set of science, and Group A's science directly contradicts Group B's science, and it's like, how do I talk with people? Because no matter who I'm talking to, they're constantly telling me that my science is faulty and I don't know what I'm talking about. Let's go to the experts. Let's see what they have to say. Like, I cannot tell you how much none of this shocked me, because I've heard these stories. I didn't quite hear about the broken glass thing. That was a little new one on me. But I've heard these stories. I am familiar with a lot of these procedures. I know what this is. This isn't some conspiracy theory that was cooked up in a back room. This is WPATH. These are the folks that wrote the rules. These are the standards of care that we keep hearing about. It seems really iffy to me. But yeah, tell me what you think. And by all means, do go and look at the actual leaked documentation. Go take a look at it for yourself. Go learn about this yourself, please. This is just scratching the surface. They were talking about parents. The doctors in this video, they were talking about how some parents, they would go in and they would talk to like an endocrinologist or whatever, and they'd come out and they'd be like, I really don't know what they were saying. Like, do these people actually know what's being done here? Like, I have not had time to listen to the full recordings. I haven't had time to listen to the whole thing. There's so much information here. Definitely go check it out, though. This is very eye-opening, to say the least. Anyway, that being said, it is getting quite late. This is a very long video. It's too long, again, way too long. There's too much information here. And this was just some of the excerpted quotes. There's so much more. But I've got to call that quits for now. Definitely go take a look at this stuff. And I hope you're all in good health, and I will talk to you guys later.